Everything said on this podcast is entirely for entertainment purposes only. This is satirical and should not be considered clinical advice in any situation. Please use your own clinical judgment, using your own knowledge, expertise, and research. Consult with your local eye department if you are unsure, and always act in the best interest of the patient. Do not listen to the things that we say and take it seriously.
Hi guys, welcome to the Glasses Half Full podcast. We are here again with Patrick, our clinical optician. He works in the Cataract Clinic. Thank you very much for coming a second week again to see us.
None of us changed.
Yeah.
I've just been living in basement.
We've not let them out yet. Like, we need another episode.
So we discussed a little bit last time about how it's different working in a cataract clinic as opposed to community. I think this episode we can talk a little bit more about cataract, given that you're more knowledgeable about that. You have more knowledge on that. My grammar is not correct today.
Today.
So when it comes to cataract and types of cataract patients that you see, what is probably the most common types of cataract that you see, and the density that we're on about? How dense would they get?
Yeah. So you say I'm like cataract specialist, but in all honesty, that I'm only like a month deep into.
Yeah.
Obviously, my previous role was assessing cataracts, but that was more for refractive lens exchange. So most patients attending those clinics had healthy lenses. They were just looking for multifocals or IANs or whatever. So I mean, in terms of assessing common cataracts, from what I've seen so far, I'd say the most common one would just be a nuclear. Nuclear cataract. Boring.
Took me by surprise, that.
Were you not expecting that?
No, I'm thinking blue dot or something like that.
Mad cataract. Nah, it's just
really bad suture cataract.
Yeah,
just
a
they're
nuclear.
all traumatic.
Yeah, yeah. Everyone's getting smacked around in Sheffield. Nah, it's a nuclear cataract. Then it's probably cortical and then posterior subcapsular. But actually, it's quite surprising, like the amount of posterior subcapsular element I've seen to pretty much every cataract. Whether it just be like a tiny dot at the back or like quite a formation of cells at the back.
So there's more of a variety in that.
Yeah, and like, do you know when you think posterior, what do you think when you think posterior subcapsular cataracts?
A tiny little thing off in the corner.
Yeah, just a tiny dot.
Yeah.
So from what I've seen, that tends to be the case like a lot of the time, but you do get them like where they're off to the side and they're quite moderate, like a fishnet, or
Okay.
you can have like quite a spread posterior subcapsular or like an inferior. They don't just come as like a generic poster.
Yeah.
So you just got to keep an eye for it.
And when you do the lens section, we're looking more at the back of it, isn't it? So you see...
Retro is your best friend.
Okay.
Yeah, so retro illumination. That's what I found works best for me.
Do you do it with slit lamp? Because you can't always get a good one with slit. Although you have dilated patients that you
Dilated, mate, yeah.
Yeah.
So on an undilated pupil, it's solid. I've realised how solid it is. Yeah. To look at a cat, that's why, realistically, if you ain't got time in clinic and you're referring, in all honesty, I'm not overly bothered what your referral says. I'm not expecting you to be grading the hell.
As long as the VA matches.
Do you know what, mate? Just put cataract, best corrected, pathology, refraction.
I like this tangent.
Yeah.
You're reading the referrals that we send.
Yeah.
Okay.
It's like, what are they talking about?
What is the ideal referral? What does that include? And what is just, when you read it, it's like, oh.
Yeah. So don't waffle. I've learned that myself, and I've been a guilty party of waffling, especially as a pre-reg. You just like patient was born. No,
Writing warrant.
Yeah, yeah. So do you know, realistically, I need refraction. So what's the current refractive status? That's important because, say for example, the myopic. So if they're a -2, they've always had the ability to see up close.
Yeah.
So if you send me a referral and I'm just getting no refractive error, then that's quite. The autorefractor is going to tell me what the refraction is.
Is that more accurate than the ones in like community?
Not really. It's just autorefractor, yeah. But the reason I mention it is because you need to have that conversation with the patient. So post-treatment, are you going to be happy to not be able to see up close anymore?
Yeah.
If the answer is no, we can adjust the surgery for a myopic outcome.
So order a lens that's fixed.
So you'll give them the option that will.
Yeah, it's quite easy to do that.
Still on the NHS.
Yeah, on the
Wow.
NHS. So you just use a different
Yeah,
powered
different
lens.
strength.
Just leave them myopic.
Yeah.
So just
overcorrect a little bit.
Correct. Yeah. So just give them a stronger lens. Therefore, they're left a
Would
bit
you ever
myopic.
do monovision? Because I've had a few patients that's come through that's like they wanted to do monovision IOLs.
Yeah.
And they've been told like try it with contact lenses first.
Do you know, you wouldn't suggest it because you're just opening yourself up for confusion and you're not there for that.
Yeah.
You're there to get the cataract out. But if a patient attended and say, for example, I've been wearing monovision lenses for the past 10 years and they've worked great. This is my dominant eye. This is the eye I use for reading.
Yeah.
That's fine.
Yeah.
You can just set the biometry to leave this eye with so much myopia, aim for plano in this eye, and just record it on your notes. Patient well tolerated to monovision, worn for 10 years. But you wouldn't suggest it as a trial.
Yeah.
You would do that more in a private setting.
Yeah.
And even then, you probably wouldn't suggest monovision.
Yeah,
it's just not worth it.
Monovision is not the way.
It's not the one.
So
Not for me, anyway.
What else in a referral then?
Sorry, yeah. So refraction, not bothered about vision, but best corrected is a big one.
Yeah.
Would you want with the refraction, or would you want a pinhole, or both, or?
Up to you, mate.
Yeah.
They do pinhole anyway, so they do pinhole when they get to clinic. So I just want to know what the VA is with the refraction, and because from there in the morning or the day before, what I do is I'll look at the clinic, and I'll just make little notes.
Yeah.
So I'll put like myopic, right eye worse than left.
Yeah.
So then I've got like a heads up before they come in, and pathology. So refraction, best corrected, pathology, because it's no good sending a patient with dry AMD to me and just putting wants cataract surgery, because are they aware of the AMD? Have you had that conversation with them? Do they know that the vision is still going to be blurry or have some distortion afterwards because of the additional pathology? So it's just knowing things like that. And also the macula is particularly important to me because not every patient in clinics that are busy have OCT done. So at the minute we're doing OCT on everyone because we're not that busy. But if it was a busy clinic, we might only say, well, I want the diabetic patients to have OCT. So hopefully you guys, if you're sending a referral, just do a quick OCT. Therefore, I just know what's going on at the macula, and you'd be so surprised at how many times you pick things up on OCT.
Would you want the image to be sent, or just saying that no fluid?
As long as you're putting it in, if you want to send the image, great, but that's not the end of the world. I just want to know, has the patient got some RPE changes? Do they have ERM?
So is that due to, for example, if they have, pretty bad dry AMD, to make sure, is describe the macula to describe reasons why they might not need a cataract extraction, or would it be more a case of, they have ERM that increases the complication risk? Or is it both?
Both. So like ERM increases the risk of CML, and then again it just reverts back to a guarded prognosis. So a patient with AMD, you need to tell them that post-treatment it ain't going to fix that. That's still a problem. Therefore, you need to continue monitoring that, because patients they don't know what's going on with their eyes. You just need to make them aware.
It's funny how you probably more so than us, we've gotten so used to seeing cataract as something, and it was like the amount of times you have a patient and you think that you've just given that you think that they're getting a death sentence by the way they react. It's like a cataract, like everybody else. It's so normal for us to see cataract and all that. But for some patients, it's a case of no, not the cataract. Don't worry.
So obviously the three main types: nuclear, cortical, and
Go on.
PSC.
You almost forgot.
Nailed it.
They're the three ones that you probably always see every single day. one question I had is there any less common types of cataracts that you see that's I guess you'd see more in your type of clinic than in our type of clinic? And then do you see things like purely just nuclear or purely just cortical without any other types? Is that also common?
Yeah,
or
you
is that
can.
less common?
Yeah, you can. I mean, you can just have like nuclear ones. I've seen cataracts previously where you just can't see the back of the eye.
Jeez.
Even with the
Absolute
dilation?
biscuits.
Oh yeah, mate. Yeah, like that.
Have you not seen them?
Dense. Of course,
Yeah,
it's
just
like
absolute biscuits in the eye.
yeah.
Like,
yeah. It's like I ain't gonna refract you. So 1 or 2 on a 0.25 change, and they've got the dentist cataract. Like, what are you doing?
NLP.
I just literally put auto refract. Can you see? No, switch it out. I'm not wasting time with that. So with those patients, you're looking more so at doing a B scan,
Okay.
which is where you're using ultrasound to see if there's anything going on. But again, guard of prognosis. We can't see the back of your eye. We're going to extract the lens. Hopefully, it improves your vision.
Yeah. So you would
Don't know what's hiding back there.
yeah, there's no retina.
So you would do a B scan on, let's say, biscuit cataract.
An absolute biscuit.
I've not heard that before.
Sharp red.
If let's say you were to see someone with wet AMD in that case, would you be like, hang on a second, we need to sort that out first, or would you be like, let's do the cataract and then they can get the AMD done afterwards?
Good question.
Depends.
I suppose it depends if they've been managed for the wet AMD or not. So if they're attending regular AMD clinics and they're receiving regular anti-VEGF injections and hospital are aware of it, then get the lens out.
Yeah.
That's what my logic could say. I'd have to check company protocol for that.
Yeah.
Don't fire me.
Edit that out.
Yeah. But yeah, you just got to use common sense. If it's a new finding and you've got wet AMD, you're going to sort that first. Get them on a fast track for AMD clinic, and then sort the cataracts.
Cool. Another thing that I wanted to just gloss over is secondary pathology that may be induced by cataract that you feel like maybe someone in the community should be looking out for before they think about just referring for the cataract, or if there's anything that can be caused by the cataract that needs to be addressed first. Is there anything in that regards that you have a bit more knowledge over?
What do you guys see? What do you guys see the most?
Well, I've honestly, like, I'm yet to even see like a glaucoma-induced cataract. I'm not sure.
I see that like it's common.
No, but like that's something that's mentioned.
Oh, so you mean what cataracts can cause, or what the
complications of cataract surgery?
Of cataract surgery.
Well, both of them, right? The surgery, and also of cataract.
Oh, okay, yeah. I mean, you're gonna have to have like a dense.
Oh, are you talking about like pupil block?
Things like that, yeah.
Okay.
Yeah. So you're gonna get pupil block with like a really thick cataract and a really shallow anterior chamber depth. But that's few and far between, and that kind of patient, they could potentially going to be a bit symptomatic, maybe. So yeah, that's pretty rare. But I mean, in terms of post-operatively, most common one's PCEO. So you're going to get to check my word in. That's going to happen probably at some point, but is it going to happen to an extent where it needs YAG? Maybe not. It might do, but you look. I don't know what the stats for that is actually, but just based on experience, I reckon it's about 20% of patients need YAG at some point, realistically. It's not bad, but like I say, a lot of that is patients with PCO that aren't bothered. They don't drive and it don't impact their vision too much, or so they never come for a sight test.
Is there a cutoff for referral for YAG?
Don't think so. No, I think it'd obviously be, there'd have to be justification.
Yeah.
So reduced vision or patient really struggling with night driving, that kind of thing.
And so when I tell someone about the cataract surgery, as far as surgeries go, pretty straightforward. In and out same day, local anesthetic. The surgery probably lasts about 15 minutes or so.
Yeah.
How does that? How should I be describing YAG?
See, do you know, YAG is it's painless, dilated pupil, in and out, 10-15 minutes max. Yeah. So I don't.
There's less risk.
Yeah, so I mean, there are still risks associated with it. Like you could completely rupture the bag and the lens could drop out, but you'd have to
Fair
be
enough.
pretty trigger happy with your laser. You could, I mean, I think the worst risk factor is retinal detachment. If you fire the laser in the wrong position, increasing floaters because obviously you're zapping away
just
some
lodging on
material.
the film. Yeah.
That's the thing. Yeah, but the simplest way I always say to the patient, it's an easy fix. There are risks associated with it, but you'll just pop your chin onto a slit lamp like this.
Yeah.
So it's essentially just a slit lamp with a laser on it.
Yeah.
A few zaps of laser out. That's it. Yeah.
Did
I
they
think-
need to do anything though? Because obviously after the actual surgery, there's drops and things like that. But
Yeah,
anything like
I
that?
think they give a light steroid for about a week.
Okay.
So like FML for like a
Yeah.
week or something.
Keep the inflammation down.
Yeah, and that's it.
Fair enough.
Yeah.
Okay. And then just back to the cataract post-op, apart from PCO, any other common clinical problems, pathologies that can happen?
CMO are not necessarily common, but
Can happen.
yeah, paleness, loss of vision, probably about
Yeah.
a month on,
Mhm.
month to two on.
So
So
that's not something that community would probably see if they're not doing a post-op.
correct, yeah.
Yeah.
But you might end up with a patient that's come to you for glasses.
Yeah.
So like, oh, I've been discharged now. They've told me to come in and get some glasses. You start refracting and like, why the hell can't I get the vision
Yeah.
right?
Yeah.
And then you put them on the OCT and
Some
then
mess back there.
yeah, so ooh. But it looks scary, but it's pretty common and not scary. Like it's self-resolving.
Yeah.
Don't worry about it. You need to take steroid drops and some non-steroidal anti-inflammatories. It'll sort.
Yeah.
I'm sure there are cases out there that are stubborn and chronic and don't disappear,
Yeah.
but most times it's sorted.
And like as an IP, you'd be prescribing one for yourself.
Yeah.
So you just be like,
Yeah.
right, I'll do this. I'll see you next week.
Yeah, but even that, I'm not like blasé about it. Like, oh, my P. Here's some steroids. I still always refer to guidelines. It's just safe.
Of course.
Yeah.
Because realistically, you've got to think of it. The way I approach it is you're in court, the GOC is reading your records.
Yeah.
What did you do?
Yeah.
Mm.
I just gave them steroids on what. How did you come to that decision?
Yeah.
Well, I referred to the company guidelines and the company protocol, or I referred to the college guidelines. You straight away, you just instantly sound like you're cautious in your approach.
Yeah.
So I always refer to guidelines.
Fair enough.
Yeah, always.
So thank you very much for that.
Sorry.
You've got to go back into the basement. We've got another episode to so
Back into the cage.
yeah. I hope this for people that are listening. I hope it's a bit more information on how cataract kind of functions in kind of surgery and what's common and what's kind of not common. So
And what to include in your referrals.
And what
Stop that waffling.
yeah.
Stuff like that. I had a fellow optom go through one of my referrals with somebody else, and just as an example, and she was tearing me apart, and the doctor was like, no, the brevity is a good thing. The no waffling.
Yeah,
So it's,
but like I used to be like, the above patient attended the clinic. I'm like, don't care. All you need to know is, patient wants bilateral cataract treatment. Notice gradual reduction in vision. Like maybe put a symptom on there like struggling driving, struggling with TV, whatever. Some additional justification. Any additional pathology. Job
wow,
done.
I'm still too verbose. I still need to cut down a little bit more.
Yeah.
Jeez.
But it's good though, mate, because you care about your job.
Yeah.
You clearly care.
Well.
Yeah.
Well.
Within reason. But you do, and you do these things when you care. You put additional information thinking you're helping the other person, but actually when you're busy, it's more of a hindrance. As long as you put in
a little bit.
the reasons in there,
Yeah.
and especially the consultants, not necessarily me as such, but your hospital consultants, they just think all optoms are just idiots. They're just what the hell are they talking
Yeah.
about?
Yeah.
So yeah,
Fair enough.
good learning for all of us.
Oh, that bombshell.
Yeah. Thank you very much for listening, and we'll catch you in the next one.